Welcome to Atlanta and the start of the 2016 NHSN annual training. We tried to order some pretty weather for those of you who have come from the north, and I hope we did all right. My name, for those of you who I haven't had the privilege to meet yet, is Nimalie Stone, and I am the medical epidemiologist for long-term care here in the Division of Healthcare Quality Promotion at the CDC. And I am thrilled that we are beginning our annual training this year with long-term care content. This is our first year where long-term care has had an opportunity to present. So I appreciate all of you being a part of this, and we hope that with your feedback, we can continue to make this part of the agenda in the future. Some of you will be here with us for the entire week of the training, but others will just be here today focused on the long-term care content. And we really appreciate and thank you for your travel and spending some time with us, and welcome you again. Just a few housekeeping items to cover before we start with the presentations. If there is an emergency, please note the nearest exit sign and the locations around the room. Safety first, right? CDC and our planners, presenters, as well as spouses and partners wish to disclose that we have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Our planners have reviewed content to ensure there's no bias, and presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept commercial support for this continuing education activity, and no specific case studies will be addressed during the training. Continuing education credits are available, and instruction on how to apply for CE credits are in your folders. Please be sure to scan in and scan out daily with Averis so we can note your attendance for the training. Also, note in the resource manual, a few handouts for long-term care are in the back. Please feel free to bring coffee, water, and snacks into the conference room. If you have any travel, parking, registration, or logistics questions, check with our colleagues from Averis at the front desk. Also, team members from the NHSN Help Desk will be out front to answer or address other questions you may have. No photography inside the CDC is allowed. Please put your phones on silent or vibrate mode. Also, we ask that all of you hold your questions until the end of each presentation. And with all that said, why don't we get started with our pre-conference session. And here in the next 30 minutes or so, I wanted to have the opportunity to share with you a perspective on some of the infection surveillance and prevention activities happening in long-term care. And I think many of you have heard me talk before, so I was trying to think of what I could say that would be novel or interesting, and I thought, well, since this is our first time up here talking with you as part of this NHSN training, let's just do a little retrospective and go back to 2009, when in August, CDC hosted the Healthcare-Associated Infections, HAI Surveillance in Long-Term Care Conference. And this was a group of academic partners, health department partners, colleagues that represented most of the nursing home professional organizations like AMDA, the Society for PostAcute and Long-Term Care Medicine, the American Healthcare Association, and the goal of the discussion was to help guide CDC's planning around implementation of surveillance, HAI surveillance infrastructure for long-term care. This is before NHSN had a component for long-term care facility providers to report. And here were some of the takeaway, highlight, summary statements that came from that conference. CDC, in partnership with national collaborators, is committed to developing a national HAI surveillance program tailored for and accessible to long-term care facilities. In addition, the top priority of this HAI surveillance program will be to provide information and support for quality improvement efforts among participating facilities. So this is the major rationale for creating this surveillance infrastructure. And we walked out with a proposed plan that there would be a long-term care component designed within the framework of NHSN based on the existing modules we had available for hospitals and other healthcare settings, but with adaptation for the long-term care population and for providers. So this was August of 2009, that's 5.5 years ago. And then a few years after that, about 3 years in fact, in 2012, we saw the release of the long-term care facility infection reporting component within NHSN. And right on the heels of that came the updated infection surveillance definitions for long-term care facilities. That was a joint effort published by CDC and the Society for Healthcare Epidemiologists of America, SHAE. And what was convenient, and not by accident, was that these efforts informed one another, so that as the criteria for surveillance were being developed by our academic partners and researchers and nursing home partners in the field, as the McGeer definitions for long-term care were being revised, we were integrating those criteria into the infection reporting events within NHSN. So there would be congruence, if you will, and alignment between those efforts. And a few months later, we looked at how many facilities had come into the long-term care facility component, and this is 3 years ago in February of 2013. So that's about 5 roughly months after the component had been released. And there were 61 nursing homes represented among 14 states, and you can see most of the states had just 1 or 2 nursing homes that had gotten enrolled, a couple which had tried to maybe actively engage nursing home providers in the conversation, had gotten a few more, and Vermont was planning this for a couple years, for several years, in fact, before NHSN came live, so they had quite a bit of traction already in their state. So this is what the map looked like 3 years ago when the component was pretty new. And here it is today. 3 years later, we can see we've got quite a few more states and quite a few more facilities. So 280 nursing homes that have enrolled and are now actively eligible to report. They may not all be reporting, and I think that's important to recognize, but one of the big hurdles, right, is enrollment. So these 280 facilities have actually made it through the enrollment process with help and successfully, and they represent 38 states plus the District of Columbia. And here you can see more than a handful of states that have worked intentionally with providers to engage nursing homes in this, supported them, and much of this effort has been led by our state health departments. How many of you are here representing your state health department today? Fantastic. Well, I applaud you and thank you for all the work that you have done in this effort. And then many of you probably are representing quality improvement organizations or QINs. How many of you are representing QINs? Welcome. So it's about half and half. That's fantastic. Well, hopefully you all know each other already. If not, this is a fabulous opportunity to meet and talk about how your activities and efforts align with one another's, especially in long-term care, especially in the next few years. So what were some of the drivers for NHSN use in these first 3 years of our experience with the component? I think, as I mentioned already, the state HAI programs, engaging nursing homes, and promoting it as a tool for supporting prevention efforts around C. difficile infection and multi-drug resistant organisms. in addition, we found that hospital systems and hospital partners were working with their affiliated nursing homes and long-term care facilities to help them start to get involved in NHSN. There have been some policy statements, probably written by folks who are here in the room, about the importance and the opportunity that NHSN reporting offers for long-term care when it comes to HAI surveillance. One of the biggest statements that came out from the Department of Health and Human Services in the spring of 2013 was the HAI prevention roadmap and the action plan to eliminate HAIs. And there was a chapter specifically focused on long-term care that made NHSN enrollment and reporting one of the top priorities for this setting. And then not that long ago, just about 9 months ago, I guess last summer, the Council for State and Territorial Epidemiologists put out a position statement that also endorsed and encouraged a use of NHSN as the standard setting for infection surveillance in long-term care. So we've also seen in this timeline a lot of awareness of the role of NHSN reporting from state and federal incentive programs. For example, all of you are intimately connected to the CMS reporting programs in other post-acute care settings like long-term acute care hospitals and inpatient rehabilitation facilities, not in addition to dialysis clinics and acute care hospitals. About a year ago, Nevada became the first state to require NHSN reporting from skilled nursing facilities, and they're still in the midst of implementing that. And then, interestingly, the survey process and the regulatory process is a very powerful driver of change in nursing homes. And if you are not connected to and working with your state survey agency and the folks that do oversight of nursing homes, I would encourage you to get to know them and make them aware of the work you're doing, because I think, again, there's a lot of alignment between everybody's goals to raise the quality and safety in these facilities. But in Wisconsin, there were surveyors starting to ask, when they'd visit nursing homes, they'd just ask about NHSN. Do you know it? Have you heard of it? Do you use it as part of your surveillance program? And although it was not a requirement, and there was no citation or deficiency if you said, no, I've never heard of it, the fact that people were talking about it and being asked about it really started to get facilities interested in paying attention. So we have kind of had a facelift not that long ago, and our website has got a lot of new training resources, and Angela and others will kind of walk you through those resources later in this session. But one of the strengths and one of the reasons why we wanted to see NHSN become a resource for long-term care was the power of standardization, the power of standardizing our approach to identifying events and tracking our data and reporting our data. And as you hopefully are aware, the component currently affords reporting options for facilities in urinary tract infection surveillance, as well as multi-drug resistant organism and C. difficile surveillance through laboratory identified event surveillance, as well as some prevention process measures such as adherence to hand hygiene and gown and glove use. And there's a lot of interconnectedness between use of antibiotics, for example, in urinary tract infections, and how that has impact on our rates of resistance and C. diff and our activities at the bedside. So there was some strategy to how these initial early events were rolled out. I wanted to share briefly a little bit of information about from an analysis that we did to look at some of our very, very early adopters of the long-term care facility component. And these were the facilities that enrolled and reported data with the first two full calendar years that the system was up and available. And that's January of 2013 through December of 2014. There were about 200 facilities that had enrolled in that time frame. And you can see the median bed size was about 100. The the daily census was comparable, 99. The median staff hours per week that were given to infection control was 14 hours a week for infection control in these facilities. And you can see the interquartile range there from as low as 8 hours a week to the high, the 75% was 24 hours. So that's still not a lot of time if you think about how much work there is to do in infection prevention and incorporate not just surveillance, but all the teaching and prevention work to make a change if you're looking at event outcomes that you want to see go down. So not a lot of time. And in that cohort, 3/4 of them had submitted at least one monthly reporting plan. So the question is, okay, you're enrolled, how many of them are actually trying to use the system? And in this 2-year window, we saw 155 put at least 1 month of reporting intention. Now, submitting a plan doesn't mean that you completed the month, right? So there's more to see there. Let's see. When we looked at the months intended versus the months of completed, you see a range, but actually it's not that bad, right? Our sort of most successful event reporting is actually urinary tract infection, which kind of surprised me a little because that's one of the more complex events to report. There's more signs and symptoms surveillance in addition to looking at laboratory data, right? So you have to do a little more in the chart. But 81% of the facilities that intended to report a month worth of data completed that. And C. difficile, I don't think anyone's surprised, is our most popular event to report, and about 74% of the time people got it done for that month. So pretty good, actually. So 83% of facilities overall who had a reporting plan or more submitted completed at least 1 month of data in this 2-year period. But then we tried to look a little bit more at the stability of reporting. So is this a one and done, or did I get in and start reporting and stay reporting? So we defined consistent reporters, people who had or facilities, I should say, that had completed at least 6 or more months of data in a calendar year. And there you can see in the red box that from calendar year 2013 to 14, we saw a pretty substantial drop in consistent reporting. In 2013, we had 70 facilities representing 75 or 76% of the facilities intending to report 1 month or more of data actually consistently report. So 6 months or more of reporting. But then in 2014, we saw that fall off to less than 50%, right? 47% in 2014. So we wondered maybe what could have accounted for that. And we looked at, we don't have a huge amount of information about these facilities, right? But we looked at, well, how did the consistent reporting cohort change geographically? And what's interesting, you can see there are a couple of places in particular where in 2013 we had a lot more folks consistently reporting, but they kind of fell off in calendar year 2014. And if those of you who work in the health departments, we have projects that pretty much go from year to year. So we are going to focus on this effort for this calendar year, and then budgets change or priorities change, or we have finished this, and so we move to our next effort. And what you're seeing is that when that external support goes away, then the internal motivation to sustain engagement in the system seems to fall. And I don't know, many of you are probably familiar with long-term care. How many of you work primarily with long-term care in your positions? Some, not a huge number, but for those of you who have worked with nursing home providers, you know that there are reasons why this could happen, that in fact, there are quite a few barriers to sustaining voluntary reporting. And remember, there are no incentives except in Nevada. There's no other place where this is a must-do. There's not a penalty or financial driver to engage in NHSN for nursing homes. And things like staff turnover limitations in infection prevention staff and resources, and we looked at the current landscape of these, and I consider these facilities perhaps the higher end of the curve in terms of their willingness to dedicate time to infection prevention because they actually went through the steps and hurdles of getting enrolled. So here we are at sort of the higher functional or more committed group, and yet there's not a lot of time being given to nursing home infection prevention and work. And there are a lot of competing priorities. So as this project ends and people move on to the next thing, it's very hard for them to maintain and sustain their engagement. In addition, I think this is an important message for all of us. Facilities currently, nursing homes using NHSN may not be getting the maximum value and benefit from their own data. And there are some reasons for that we can explore, and I think some of you who have experience already working with nursing homes and NHSN reporting could probably teach us why some of those challenges are there, but we have to make NHSN more useful and valuable to the providers so that they want to stay involved. So external partners like you and programs that drive NHSN use by nursing homes are incredibly important right now to help them become aware of the system, but also to use it. And participation in collaboratives really does help maintain engagement and provide some scaffolding, if you will, for accountability. It also really creates a powerful forum for sharing experiences and seeing how an individual facility's experience may compare to peers. And that's, again, something that you all can bring to those providers that you're working with. So what's going to happen in the next few years? I just wanted to highlight things, most of which you already are aware of, but just in case you hadn't heard, there are some great opportunities in the next year or two coming to nursing homes to help support these kinds of activities, and the work that you've already been doing lays the foundation for that. So we've seen incredible attention to reducing antibiotic-resistant organisms and C. difficile in our communities, and we have messaged quite a lot in the last year and a half the importance of health departments to be at the hub of coordinating work in communities to reduce resistance and improve antibiotic use and stewardship across the healthcare spectrum. And there are a lot of different activities that colleagues in health departments can engage within, including looking at the way transitions of care occur and where do people move and how do they move. And we know that there are certain dyads or triads that share a lot of patients within a community or a region, and if there's a problem in one of those facilities, it's going to somehow influence and impact those others that are sharing that population. So understanding that continuum of care and how people move is a critical piece to addressing prevention. Promoting NHSN surveillance as a vehicle for mapping and tracking facility-level data, and we see the benefit of this when we work with our hospital partners who have a lot of data for a few years now, and you can really see the way we can target our prevention work with those facilities that seem to have a bigger problem. And wouldn't it be nice to know where those pockets of need might be in other parts of the healthcare continuum, in particular nursing homes, where we don't have a lot of data yet? There are opportunities for health department partners and quality improvement organizations to help with implementation of prevention and stewardship activities to bring, again, community of care partners together to facilitate conversations, improve quality of care and information flow when people are moving. And there's an opportunity really to measure the impact, the change of all of these activities and find those gaps and close those gaps. And this is where we want to see our regional prevention work take us. In addition, and not by accident, our colleagues at CMS are working to drive C. difficile prevention in the same, using very similar strategies around collaboration and information sharing and identifying those strategic communities that need support. So the CMS C. difficile reporting and reduction project, which has been announced and is in the early stages of getting kicked off, is happening within the framework of the National Nursing Home Quality Care Collaborative. And those of you who work with the QIO programs are already very much involved in that effort. In fact, in its first few years, the Nursing Home Quality Care Collaborative has already brought a large number of nursing homes into the group, over 7,000. This CDI project goal is to recruit 15% of nursing homes across the country. That's roughly 2,000, a little over 2,000 facilities to enroll into NHSN and sustain CDI reporting over the course of the project. And you can see it is a multi-year effort. And the participants, facilities working in this collaborative in the CDI project piece of it, which you can see is a subset, right, of the larger group, they'll receive training and support on CDI reporting. And then everyone involved in the collaborative will get education and resources around C. diff prevention and antibiotic stewardship. And you can see some of the types of information and pieces of that program that we'll be rolling out over the next few years. So why do it now? Because getting involved now and doing this work now will hopefully get these facilities prepared for whatever might come in the future. When we were at that conference all those years ago in 2009, talking about, well, where else could we go with HAI surveillance data? Here were some of the things that we could eventually get to. We could look at the scope, the burden, if you will, of HAIs in long-term care at a national level. This is how we leverage the powerful data of NHSN and all of the information reported by hospitals. We can look at the HAI incidence rates in this setting and inform our prevention and control policies and efforts. We can be strategic in the places that we work. We can provide quality of care measures for regulatory and licensing, which is how we've seen NHSN evolve in hospitals and other post-acute care settings over the last decade. And eventually, perhaps, there would be the opportunity to use those same measures to guide transparency and making this data that is so powerful accessible to all, including our consumers and the patients themselves who rely on these facilities. And there are stepstones along that path. We're not quite there yet, but I do hope that you're aware of a large regulatory update being made to the nursing home requirements for participation that CMS released in the summer that incorporates quite a lot of new expectations for infection prevention and control programs in nursing homes. This is just a quick highlight of some of those new regulations, things like a risk assessment of the population that guides the resources and staffing planned for care in that building, integrating infection prevention into the larger quality assurance and performance improvement program that every facility needs to have, having an annual review and update of the infection prevention program, including policies and procedures, again, that would keep up with the changing population that you're caring for in the building. Something very new is the expectation of antibiotic use protocols and monitoring as part of stewardship in every nursing home, and designating an individual to be the infection prevention control officer, and in particular making sure that individual has specific infection prevention training, which is a huge need and gap right now, which has to be closed in order for any of this other stuff to work. And then having not only that designated individual with infection prevention training, but also making sure that for the bedside frontline caregiving staff, there is education and training as well around infection prevention practice. So very positive changes, but I do think this is a big, heavy lift as well. And so to be aware that your partners that you're reaching to bring into a conversation about NHSN are also seeing this looming out there in the future. They have to see how working with you and working within your programs are going to help them achieve these goals and actually serve as resources to their programs and not as perhaps distractions, right? That I'm not going to get this work done that I must get done. So we have to do a lot to align our efforts. I wanted to quickly mention that there's some legislation that came out in the fall of 2014, so it's been out there for a little while. The Improving Medicare Post-Acute Care Transformation Act, or IMPACT Act, which was intended to align measures of quality and reporting among all of the providers delivering post-acute care in this country. And hopefully this language, this terminology is familiar to all of you, that we have acute care hospitals, right? And we used to just focus so much of our work there because people stayed there for a long time, and generally by the time they were ready to leave, they were safe enough to go home. But now, as we've seen lengths of stay change and shorten, and we've seen different payment incentives, we've got a whole new crop of providers that help patients who are leaving acute care hospitals but are not ready to go back into their homes be safely transitioned. And this post-acute care arena is probably the place where we need to be starting to shift all of our focus, because people are still receiving high-level acute care, right? So these are long-term acute care hospitals that are, for intensive purposes, like step-down ICUs. People are on ventilators, they're receiving IVs, they have wounds, and we know that those are the trifecta of risk factors for resistant organisms and antibiotic exposure and the complications from that. We have inpatient rehab facilities that are trying to strengthen somebody and get them independent again before they can go back into their environment and home and be strong enough and safe enough to recover their function. And then skilled nursing facilities, which are the biggest post-acute care provider, also providing more and more, not a destination for care, but a bridge. So I'm only coming for a few weeks to rehab or get my skilled care needs met before I go back to my home in the community. So right now, there's a lot of differences in the way payment is going into post-acute care, and also the way we track and measure quality in these settings. The goal of this legislation was, frankly, to better align and to make it more equitable, because you may be receiving very similar care in two different places and getting very different resources. And that's kind of a problem. So this was intended to look at the whole post-acute care arena and address some of those disparities in payment and measures of quality. And so currently, we know that CMS has quality reporting incentive programs for long-term acute care hospitals and inpatient rehabilitation facilities that include NHSN reporting, right? Everybody's aware of that. And now we have kind of a door open that if we want to see alignment and standardization across post-acute care, that NHSN reporting could be a natural next step for skilled nursing facilities. And that's the reason I raised this today. It's not here yet, and we don't know when, but I think that there's precedent and there's potential now for that to come in the future. So just to summarize, I think all of you have seen this yourself, that nursing homes are really being expected more and more to take action in tracking and preventing the spread of HAIs. And we hope that providers will see NHSN as a resource to support their prevention efforts by providing that data for action and allowing them to track their current opportunities for improvement and measure the change in their efforts. Nursing homes are starting to look at NHSN, and thanks again to you, we're starting to see reporting and use of the system grow. We have evidence that consistent reporting can be done, it's feasible, but it takes a lot of external support and resources. And we need to continue leveraging these opportunities coming in the next year to grow the industry's involvement. And the message, one of the key messages I hope that you all agree with and can take to frontline nursing homes in your states is that this is an exciting opportunity to get involved now, take advantage of the help, take advantage of the resources and the knowledge that all of you are going to bring to them, so they will be prepared for whatever the future might look like. Facilities that are now starting to get involved in surveillance and prevention programs will be seen in their community as progressive, forward-thinking leaders, and that they will have in place a lot of the expectations of programs to meet whatever regulatory or quality incentives may come down the road. So I'm going to stop there, and thank you so much for your time. I think we have a minute maybe or two for questions if anyone has a question. Thank you. Yes, here in the front. So the question, for those of you in the back, is in long-term care, oftentimes residents may have a primary care physician that is not a part of the facility, responsible for their prescriptions. And if we're talking about antibiotic stewardship, how do we engage those primary care providers in the discussion and engage them? It's a very good question. Long-term care is a large spectrum, right? And in nursing homes, generally, there are physician leaders that can help corral the providers practicing in their building. These are the medical directors, the physician leaders in those nursing homes. But when you start to move into some of the more community-based facilities, residential care or assisted living, then the model changes, and you do have each individual person has their own caregiver, their own doc, and there may or may not be somebody at the building itself coordinating those care decisions. Our division does recognize that stewardship has to come, and the message around antibiotic use has to be across all care settings, so hospitals, long-term care, and outpatient. And we do have actually quite a lot already around improving antibiotic use in primary care for pediatrics, and we've started to move that discussion to look at adults who are receiving antibiotics for respiratory tract infections. We know there's a large spectrum and a lot of overuse of antibiotics for things like bronchitis, for example. So there are members of our team that are focused on outpatient, and there are conversations with some of those primary care providers and even things like minute clinics, and there's a whole new world, right, of primary care evolving in urgent care. So we are talking to those providers and figuring out how does stewardship look in outpatient care. But you're right, we do have to make sure we continue to expand that. Anybody else brave enough at the start to stand up? Yes, in the back. So help me see how that, what could we do? The question is, how do we help improve communication at care transition actively sort of now, instead of trying to look back at old data and say, oh, there's a problem here, we should go. We have put some pieces of, I guess, tools out, like there's a interfacility communication transfer form, which actually I have to credit our colleagues from Utah. They were the ones that got us started and really very graciously allowed us to share with the rest of everyone out there that example form, right, that you can use to catch key infection prevention, and antibiotic use was there, and history of MDRO, carriage, or infection was part of the tool. So we have health departments who are trying to operationalize that. within collaboratives that bring hospitals and nursing homes together, it's a little tricky to have real-time data when we don't have much data yet from long-term care. But how many of you are familiar with the TAP analysis within NHSN? I see several hands. Yes, good, that's wonderful to hear. I'm sure it'll come up again probably this week. But that kind of, the goal of that strategy is to target those communities or facilities where they're having SIRs that are higher, and that could become, being the more and more of you that have access to that data in real time and have groups sharing information with you, that can be used perhaps to feed back more quickly information to the community to get that conversation going. But we can talk. I'd love to hear some thoughts. And I know many of you do work with cross-collaborative settings, right? You bring groups together already, so maybe there are forums that exist to have that conversation and to make that more of a active intervention within your groups. So I want to be mindful of the time, and also I'm probably the least important person up here this afternoon, because my colleagues who are coming up next are really the folks who make NHSN go and provide the educational resources and tools and content and slides that you hope can take advantage of as you go out and engage nursing homes